On this segment, we'll be placing a long leg cast. First thing you want to do is we like to position them in a sitting position so that we use gravity in our favor. This helps align any fracture so that it doesn't displace by moving them around so much. Typically you can do these recumbent if you'd like to, but you also run the risk of making the patient very uncomfortable. You get a lot more movement, especially in a tibia shaft fracture that you're trying to stabilize.
Here we're bunching the stockinette. You can also do two separate stockinettes in different sizes, using a larger size on the thigh area.
One thing that you always want to do is you're always checking your alignment, talking with the patient while you're doing this, keeping them at ease. That's very important. As you slide the stockinette up, just be smooth with it. I like to try to stabilize the back of the heel as I apply this and make sure that you don't cut yourself short on the proximal or the distal ends.
You can tell he's being very cautious with this patient because he's probably in a lot of pain.
Patients tend to hold a little bit still on this application because it hurts. Every once in a while they'll start to rock back, and you just keep talking to them, keep working through it. Check the back popliteal area to make sure there's no wrinkles in it. Reposition, make sure everything's staying vertical with gravity pulling it in the direction you want it to. Foot placement is essential here. Oftentimes if you have a very unstable mid-shaft fracture of the tibia and fibula, but you want to keep the foot in plantar flexion to avoid any malalignment such as reek or bottom. A lot of times you take it as the patient will allow you in terms of 90 degrees versus 15 to 20 degrees in plantar flexion. Patting the heel on a long leg cast is essential. A lot of patients will rest that as they sleep or in the recovery stage. Oftentimes that will cause some severe blistering. For some reason, pediatrics are notorious for this. You'll see that we put adequate padding on the heel and work distally to proximal on this.
Every once in a while you have a fumble where you drop your padding. You can easily just rip it off and get a new roll and start padding it up, whatever works best for you.
We're going to start out as if we're doing a short leg cast, and this way when we bring the patient up onto the table it will be an easier transition.
That's what our main goal is to establish a stable environment here with the short leg cast and work your way up. Once again, constantly checking your patient. Make sure that they're maintaining that position that you want them as you apply the cast. So applying your cast rolls, you as a cast technician will learn what you feel the best with in terms of the size, 3-inch versus 4-inch. Personally, I like 3-inch for the distal end. It gives me a little bit more contour around the heel because that is always a spot that causes wrinkles, and the 4-inch seems to be just too bulky for me at this point. You'll learn what you like the best and what works for you. Obviously, you'll kind of gauge that off the size of the patient. Wrapping around the heel, you just do it evenly and just let it flow. Oftentimes, if you fight this, it actually will cause wrinkles in the anterior part of the foot. So just go with the flow, and if you have to backtrack over it a couple times, that's okay, because strength in that area is imperative to keep it from indenting in on the heel.
You'll notice here Lance had 2 separate rolls of cast material ready to go. So he dropped them both in before he started and drained the water out of them, and then set the one close by. So as soon as he got done with the first roll, he picked up the second roll and was able to just continue going.
At this point, you just focus on adequate strength in the lower leg. Just treat it like you would a lower leg. You want to get good 3 to 4 layers here so that it is strong. And once again, reposition, check for alignment. Always go hip, knee, first web space. At this point, if you have to apply any valgus or varus molding, this is a good time to do it. Also check the back side so that you don't have any wrinkles in the Achilles area.
Positioning will always be dependent upon your provider. Always go with their instructions in all your positioning for these types of casts.
And don't forget to check the x-rays. You always need to view the x-rays before you apply the cast so you know exactly what you're treating.
Oftentimes, people are not in a very good condition. Often they're in pain. Sometimes they get nauseous. I've had people who vomit, who go into muscle spasms, and you have to just be patient and talk them through it and do your best to stabilize and hold the extremity while they go through their situations. We'll move the patient up onto the table and begin our proximal portion of this long leg cast.
Once you get them comfortably set on the table, this is where you can have somebody come help you and help maintain the proper position. You mainly want to get that knee flexed just a little bit. There's a whole bunch of different degrees that you can do it at. We prefer right around 30 to 40 degrees, and that just gives them enough flexion to be able to get in and out of a vehicle, to get in and out of bed, to be able to transition, and then also to be able to keep their foot and their toe off the ground as they are on crutches and moving around.
Notice the extra padding on top of the kneecap, do a little extra padding on there for bony prominence. Then as you work up to the thigh, you want to make certain that you have plenty of padding up here as you roll it back. This is an area that can irritate the patient consistently while they sit, while they lie down, whatever it might be, if you don't pay enough attention and have enough padding at the very proximal end of this.
It's always a good idea prior to putting a cast like this on to explain to the patient beforehand what the process will be and what you'll be doing, so the patient isn't uncomfortable as you're pulling the stockinette up and padding up near the growing area.
You'll notice right here that we're focusing on the first web space, patella, and also the femoral head, and that's the alignment that you try to achieve as you apply this long leg cast.
And as you can tell there, the person out on the distal end holding that lower extremity has a perfect line to line that up. So it would be their job to keep an eye on that alignment the whole time the other person is casting.
As you overlap an existing cast, it's always good to capture as much of the distal end as you can. I have seen in my own experience and other casts that have been applied, that if you don't overlap that enough, that it'll actually crack and twist apart at that junction. So capture it at the distal end and then work your way up from there.
As you can see there, he started at least halfway through the tibia to be able to have that top layer adhere to the bottom fiberglass that's already hardened before we move the patient. So now it's going to adhere to that very well, and it won't break down. You'll have a less of a chance of getting wrinkles in that popliteal fossa.
We talk about the distal end being rigid enough that the patient now gains a little bit of trust in you as a cast technician that you're not going to hurt them. They become a lot more comfortable with that lower distal end of the cast set up enough that they're not moving around, and they tend to relax at this point, which makes it a little bit easier for the leg holder so that they can align that toe, patella, and femoral head. You work your way up to the proximal end. You're gonna get a good 2 to 3 layers around here to keep it nice and rigid. One thing that I like to point out is that you want that proximal end to be pretty rigid before you pull your stockinette back. If you get a little bit ahead of yourself and that cast has not cured, as you pull the stockinette back, it oftentimes will wrinkle. And that's something you don't see until you take your cast off. So learn from your mistakes. When you take a cast off, evaluate the ends, evaluate everything, and you can see where the weak spots are, where you might need to strengthen it for the next time.
Again here, just showing the proper way of molding. The person out on the distal end again is maintaining that alignment, and the person on the proximal end is giving just a perfect supracondylar mold right there on the distal end of the femur to mold the patella and to keep it from pivoting or shifting at all up there on the proximal end.
That mold is very important. As you're all aware, after 2 to 3 weeks in a cast, you'll experience a great amount of atrophy, and by molding it, it helps to keep that leg stable so that you don't get rotation on it.
You can always tell an orthopedic cast, so practice that as you're looking around and just seeing different casts come into your clinic or wherever you're working at. But you can tell that they've visited an orthopedic clinic if they've got that really good mold on it and it's not a cylinder cast. If they have that atrophy, that cast up there on that proximal end is just going to have a big gap. You'll see gaps up to 2 inches where that thing's just pivoting and shifting.
And anytime you create movement inside the cast, you're going to get abrasions on your skin because there's movement, and they're going to move it, and it's going to cause abrasions, and it's going to cause big problems.
Take a little caution in rolling that back. You want to pull it snug, run your fingers across there to make sure there's nothing in terms of the stockinette that would be wrinkled underneath. This is kind of what distinguishes you from other cast applicators, is that you will have a really nice end, and it shows that you're concerned about the welfare of your patient too.
You can drop in however many rolls you think you'll need to finish out the cast.
One thing we like to do is get a couple rolls, fully inundated with the water and start your application. You actually want this to set up a little bit faster, so if you give it a few extra squeezes, get that water out.
Here's another instance where you can decide on your best judgment what size of cast material you will use to finish casts. On a long leg, you can get away with 3 or 4 inch, because now that you've got a rigid surface underneath, you can pull a lot harder and you can pull the edges out.
One thing about your overlapping, as you start to rub this, sometimes it doesn't matter how hard you rub it and try to get it as smooth as you can, there's always going to be some ridges. With the aid of a person holding that cast, you can get a little aggressive and rub those ridges in so that they are a lot smoother.
Heard of some providers and cast technicians using lotion, and they'll actually put lotion on there and rub it down really good and smooth out all the edges.
As you apply the last portion of the cast is a good time to evaluate the strength of the heel. If you have to do a couple passes over that to strengthen it, this is a good time to do it. Make sure you catch those last little portions of it so you don't have any white smiley faces on the back of the knee while they walk out. You'll find a lot of times that you are your worst critic. That's a good thing. I put a cast on, and there's so many times I look at it and say, I could have done better. It all comes down to the nature of the fracture, how painful the patient is, and that'll determine, how fast you need to work and how careful you need to be.
Make sure you continue to rub that last edge. We don't like fracture edges. We always cut those off, but make sure you rub it down really good so it doesn't peel back on you.
We saturated the ace bandages in water, wring the water out, and lay this on your cast material while it's still pliable.
If you put it on dry, it'll stick to that resin on the cast material, and then you're peeling it off.
You can really crank on it, and it'll help lay your edges down so they don't come back up, and it actually gives it a really nice looking finish.
So let that set just a few minutes, and once again we're just showing you how well this is aligned, and also made sure that the toes are free from impingement. This is probably one of the more technical lower extremity casts. One of the reasons is because you're dealing with someone, A, who is in pain, and B, who may have a very displaced fracture. As you're aware, at some point we can even discuss wedging casts, and we do a lot of that. We'll apply it, let it set up, bring it back a week later, and apply a wedge if we need to.
So remember, as you're cutting lower extremity casts off, you want to be cautious of the medial and lateral malleoluses. So before you cut, kind of eye where they are and be cautious that you cut around those, because those are prominent areas on the cast where you'll hit.
And we can't overemphasize the fact of bouncing your saw blade. Do not hold it in one spot. That's what generates the heat.
It's always good practice to feel your cast saw blade on something like a long leg cast where you're going to be cutting quite often.
When a patient tells you that you're burning them, I've made it a practice to never be so cavalier to say, this saw doesn't cut people. The minute you say that, you may nick them, it may get hot, and they've just lost their trust in you. So if they do complain, stop, touch the blade, make sure it's not hot, and at that point, they can relax. If you are cutting a damp cast, one that hasn't quite cured, you will tend to heat that blade up and they will feel that heat immediately. Listen to them. You know, if they tell you it's uncomfortable, stop.
While cutting this off, you can tell that I cut around the distal end of that stockinette. That's the piece of the stockinette that was folded back. So all you have to do is cut around the top part of that, same thing on the proximal end, and then you can peel that shell right off from the cast padding, and then you just cut right up the cast padding and stockinette and lift their leg right out.
When you're done, examine your cast. Look for those flaws or imperfections, and so that you can improve on your next one. You'll learn a lot from your own mistakes.